had a great session today to talk about how we might address some of the inequities in outcomes for patients with AML. I think what we need to think about is very broadly about some of the issues that are really quite pertinent to our patients. So things like addressing outcomes that vary between older and younger patients. So from the extremes to the older patients that maybe we may have some biases about in terms of what they could accept in terms of treatment, whether they might be able or willing to undergo a transplant. We need to think about how we address that. Secondly, for the younger, the teenage and young adult patients, we know that there are discrepancies in outcomes from US data, which suggests that even patients with good risk disease may do poorly in comparison, so in the Black population, in comparison to white patients with a similar genomic profile. And I think there's trying to understand what the reasons for that are really crucial. It may be to do with the disease biology being different in different races, but there are also interlayered with that a number of other issues, for example, thinking about socioeconomic status, education, and how these factors can impact on a person understanding of entry, for example, into clinical trials, but also we know that when we think about race, that when we think about race, that certainly historically there have been issues with, and still going forwards, there's been many issues with people perhaps having, from certain communities, having less trust of a predominantly white healthcare population in terms of the professionals that they may see. That can lead to lower engagement or potentially seeking barriers to seeking medical advice or treatment, and specifically entry into clinical trials, which we know can often be less well represented by certain ethnic minorities. I think we're in a time now where we have to think globally. There are clearly differences in drug availability and access according to your GDP. So for the low to middle income countries, clearly their AML outcomes are going to differ from countries that have access to some of the fancy new drugs that we are now able to access, which is great for us, but how do we address some of those inequities? And even within the UK, how do we address maybe geographical variation in treatment, because you may live in one area and your particular physician may feel that it's appropriate to refer you for a transplant, but maybe if you live in a different area, there may be their own biases about whether that's an appropriate treatment. It doesn't happen, just as an example. And I think one of the main issues for us is that we lack the data to really understand what's happening. So going forwards, I think we need to work as a community to more deeply understand what the impacts of potential areas of inequity might be. So we can list, age, sexual orientation, gender. We can list all these things, socioeconomic status. We can say these things might impact. But as I presented in my study, in my talk, these are factors that we think are important, but we lack the data to really tell us what's going on. And that's where some of the innovative approaches we're using in terms of big data, modelling, trying to understand what the inequities might actually be, mining the data from clinical trials that we haven't really used to understand some of these questions before. I hope that we can first get the data to understand where the gaps are, and then secondly, be able to actually, in a focused way, tackle those issues that need to be addressed.